It is my pleasure now to introduce the third speaker, Dr. Rania Abusamra, whom I just have actually met, consultant pediatric pulmonologist at Mediclinic City Hospital, and assistant professor at College of Medicine, Mohammed bin Rashid University in Dubai, who is going to talk to us about the new era in the treatment of cystic fibrosis. Take your time, your presentation is still coming up. So.
Good morning, everyone. Thank you so much for the organizers and Dr. Ahmed for inviting me. Thank you, Dr. Rania, for introducing me. I'm the only pulmonologist among three significant cardiologists. And I'm going to talk about cystic fibrosis today. Can I check if among the audience anyone has managed any child with cystic fibrosis before? If you just raise your hand. Okay, good. We've got a few. Okay, although cystic fibrosis is now in a rare disease conference, but we'll find that it's becoming less rare and rare with time. So, start. I have 34 slides, and I have to go through them over 20 minutes, so I'll try my best. Okay, so today is my talk is a new era in cystic fibrosis management, and I have no conflict of interest to disclose. The scope of my talk will include the pathophysiology, inheritance of cystic fibrosis, and then the diagnosis, how important to diagnose early versus late. I'm going to share two cases, the treatment, and the new advances in treatment. I'll start first with the two cases I have. Both are cases from UAE. So the first case is a 7-year-old lovely Ethiopian boy who was born in the USA in 2015, had normal newborn screening there, but then at the age of 4 months, he presented with failure to thrive and chest infection, and they done some investigations and diagnosed cystic fibrosis with homozygous mutation of that gene as a class 1. We're going to talk about the different classes. But then he went under the USA cystic fibrosis team, and he was managed properly, started all the regular medications. Parents moved back to Dubai, where the father works in Dubai. And then 2 years later, he was admitted with pseudomonas infection of the lung. So this child, although living in the UAE, but he used to go twice or 3 times at least to the USA to be seen by the cystic fibrosis team, and he's been managed via emails as well. And then he was treated for that pseudomonas, but 2 years later had another pseudomonas infection. And then presented to my clinic in 2021. And at that time, he didn't see the CF team in the USA for 2 years because of the COVID-19 pandemic and drug restriction. And he came to me with an acute exacerbation for chest infection, and the weight, for these children, we have to make sure that their weight centile is around 50th centile. And his weight actually dropped at that time to 25th centile. So I treated the acute problems, and we worked with adherence, and I started seeing him. And over 1 year period, he had recurrent infective exacerbation. He had at least 6 courses of oral antibiotic. And when we treat these patients with oral antibiotic, we treat them every time for 2 weeks. And the weight also has not been that great, so I referred him for flexible bronchoscopy. And flexible bronchoscopy is a common diagnostic tool. This is called that we look inside the lung, that we use for different types of respiratory patients, but it's a common practice for cystic fibrosis when we need an accurate sample from the lung. And this is what I found when I did his bronchoscopy. You can see the very thick and like slimy secretions. It's quite thick, it's difficult even to suction it. And we sent that sample to the lab and we found Staph aureus and serratia, which is within 40 hours we got the sensitivity and the bacteria. We started him an IV antibiotic. He really improved, went home. But then, 4 weeks later, because we sent the samples for routine, we're looking at TB and NTM. So 4 weeks later, I got a report from Rashid Hospital. This patient has got mycobacterial abscess. This is one of the NTM, and it's not good bacteria to have in a cystic fibrosis child. But to diagnose infection for NTM is not just having a positive sample. You need to have clinical picture and radiological features as well. So we sent him for a CT scan. And this is his CT scan. So he started to have bronchiectasis. These bronchiectasis, it didn't really show on his chest X-ray. Only you can see the severe one. The mild form, you don't really always see it in the chest X-ray. And that's why in the old days we used to CT a lot, cystic fibrosis patients. But now we stopped doing this because of the radiation exposure. So we only CT when we need to find something. So we've done the CT, he's got bronchiectasis. I don't know if this can point. Can I use pointer? Okay. So here the bronchiectasis. Can you see that there? These nodules, or tree and bud, these peripheral changes. You can see this in NTM. But anyway, the child really improved a lot after I saw him, after the IV antibiotics. So me, with liaison with the CFC chair in the USA, we decided to go on to treat for NTM because the treatment so long, so aggressive. It's 3 weeks of IV antibiotic, 3 different IV antibiotics, and a whole year of nebulized oral antibiotic. So we decided to go there and not to treat for NTM. And then the latest progress, the last time I saw in my clinic. So from the 2021, the lung function, it used to be in the 17% of predicted. It improved, it went up to the 90s. So that's good. Brilliant. And the weight went from 25th centile to 50th, excellent. And then he less and less having chest exacerbation. So from December through now, there's no need, didn't need any antibiotic. So that's a good thing. This case, and not this case, good progression. If you compare this case to the other one, 15-year-old Jordanian girl, she was born in 2007, no newborn screening. At the age of 9 months, she had chest infection, severe failure to thrive, and then being investigated, diagnosed with cystic fibrosis, homozygous delta F508. This is the commonest mutations here. From 2008 to 2022, she hasn't been really under any CF services yet. So she's been seeing different, she's been to every single pediatrician in Dubai. She's seen so many doctors, not just in Dubai, in Jordan as well. Poor weight gain, she had pseudomonas, she required hospital admission every 2 to 4 months for 2 weeks every time with pneumonia. And then when she presented to me in May 2022, she looked really bad. 15-year-old, 25 kilo, really tiny, breathless, crackles, wet cough, hypoxic. She was hypoxic in the clinic. Her saturation was 92. I was like, oh my God, where to start from? And lung function, it's just really bad. 22% predicted of her age. And this is her CT scan. I got the CT scan CD and downloaded. Basically, you can see the cystic changes. Severe bronchiectasis. So I had a plan. We're gonna do bronchoscopy, we're gonna check what type of pseudomonas, maybe you've got NTM, we're gonna refer you to the endocrinologist to see if you've got diabetes, because this is something you can get with severe cystic fibrosis. We'll send you for the gastro team to help you with the malabsorption, and we'll assess your bone. So many plans. And I think I scared the family, and they never came back. And I lost this patient, unfortunately. And the other she's not gonna survive. This is like a 1 year, 2 max if she makes it. Right, so what's cystic fibrosis? Cystic fibrosis is a genetic disorder that affects multiple organs, mainly chest, lungs, and pancreas. It was the gene, the CFTR gene was first identified in 1989. You see that boy in the science journal at that time. And it was identified to be in chromosome 7 with autosomal recessive inheritance. And CFTR protein is basically a channel at the surface of the cell that control transmissions of chloride and other molecules. In terms of statistics, it's the most common genetic disease among Caucasians in Europe, with 1 in 2,000 incidents. It's less in Africans and Asian. In terms of the region, Arabic countries don't have really clear studies yet, but I guess with the newborn screening, we're going to have more accurate studies going to come up soon, hopefully. But so far, the prevalence of CAP has been estimated that can be anything in between 1 in 2,500 to 1 in 5,000. And we have as well some studies showing what common mutation that we have in the region, which is slightly different from the Caucasian European population. So the CFTR protein depends on your mutation you have. Where is the problem? So as I said, it's a protein at the surface of the cell. It transmits chloride and water and other molecules. So if you have no synthesis whatsoever, it's class 1, which is not great. If it's synthesized, but the process is not correct, so it doesn't reach the surface, it's class 2. And this is where most of the mutations, including delta F548, locates. And if it's synthesized, it reaches the surface, but it doesn't really function, this can locate between class 3 to class 5. Why it's important? Because when the chloride goes out to the surface, the water will follow. And that's why we have thin mucus. Okay, you've got hydrated, moist surface. The cilia in the lung can work properly. But when there is no water there, the secretions become really thick, like gum, sticky. The cilia doesn't work. And then we've got a hub for thick mucus, difficult to clear. And this will attract all the bacterial, viruses, and fungus, and just name it. And because we have secretory cells all over the body, cystic fibrosis affects everywhere, literally. The endocrine system, the lungs, the sinuses, ENT, even the heart, bone, all over. But in terms of how they present, commonly, they present with failure to thrive, recurrent chest infection, bronchiectasis, meconium ileus. If you have a baby born with meconium ileus, you have to look for cystic fibrosis. And if children has got because CF, as I said, is a spectrum. It can be class 4 or 5, which is really mild. These people might just present later on in adulthood with infertility. And based on what class, what mutation you have, an environmental factor like how frequent you were exposed to infections and the nutritional status, then how bad is your cystic fibrosis and severity? How we're going to diagnose it, newborn screening is the most important tool. We need to be proactive. We need to diagnose these children very early because early detection means early intervention means improved outcome. In the newborn screen, we check for the IRT. So initially, you do that, the drops, you can see the IRT. If it's high, depends on which country. So for example, if it's high IRT in the UK, on the same sample, they can do their genetic panel. Here in the UAE, if it's the first sample shows IRT is high, you have to repeat it within 2 weeks. Okay, not after 6 weeks, which happened before. Someone repeated 6 weeks later, became normal, but the child has got cystic fibrosis, and that delayed the diagnosis. You have to repeat it really early. Definitely within the first 4 weeks of age, better within the first 2-3 weeks. Okay. Fine. So you've got the first newborn screen, definitely diagnosed CF or a predicted CF. You have to speak to parents. This is like breaking bad news. This has to be done by a cystic fibrosis specialist, either nurse or doctor. Because if you mention CF to parents, they're going to go and Google. And there's lots of misleading and gloomy information in the net. of the hospitals, they have it, cheap as well, so do the fecal elastase to look for there's pancreatic sufficiency or insufficiency. And obviously the sweat chloride test, which is the gold standard. Okay? And for sweat chloride test, if less than 30, no CF, more than 60, it's CF. If in between, this is the gray area. This is the gray area, and we have to do more testing to check. Sweat conductivity, which is commonly used here in UAE. In fact, there is not a single center where we can do sweat chloride test in Dubai. Even in Jalila, they only do the sweat conductivity, which is an old version. And it's good for screening, but it's not the best. As you can see in Abu Dhabi, they have the sweat chloride test. But we're in the process of it to get sweat chloride test. Fine. So, if the sweat chloride test is less than 30, that's it, this is not CF. If it's more than 30, then we have to do genetic testing. And the genetic test, if you're in a country where you know the commonest 90% of your genes do the CF. But if we are here in UAE, where we have so many people from different countries, we're not sure what's the panel. So it's better, and I advise, for a whole exam sequence. Just send them to Dr. M. Diagnosis, we need to manage. We need to be proactive. Management, the most important bits of management is airway clearance, get rid of that slimy mucus, support nutrition and antibiotic. And obviously, if acutely unwell, acute therapy and maintenance means seeing these patients frequently in MDT outpatient clinic. Nutrition, good nutrition is found to be closely related with the pulmonary function and survival in CF. This is really important. So these patients, when I say pancreas, most of these patients are not functioning, so you need to replace the pancreatic enzymes by creon, the correct dose, and also high dose of fat-soluble vitamins, we call it DCAS. And we have to aim for a BMI at least 50 percentile. For airway clearance, right, it's important because respiratory disease is the commonest and the commonest leading cause for death in these children. So for airway clearance, should be daily done. We use these gadgets. If you look at the aerobica and acapella, this is a positive respiratory pressure. We have to do this on a daily basis. It pushes the phlegm out. Nebulized hypertonic saline, which stimulate the coughing and hydrate the thick mucus, so it will be easily coming out, and obviously mucolytic pulmozyme. Exercise really important for these children. And low threshold for antibiotic. Don't worry about resistance in these patients. We're going to lose the lung. They're going to end up with a lung transplant. With all the new diagnoses and advances, the survival rate went from 100 years ago, they used to die in the first 2 years of life. Now, currently, they can reach easily 40, the expectancy around 40 years of life. However, this is even before the new modulators. Let's just skip these two. So, modulators. These are a CFTR modulator, a life transforming. It was all over the news in Europe, UK, and USA. So what are these modulators? They are small molecules directly address the functional protein defect that causes CF. So as I say, this the CFTR protein, the gene is not producing the protein but not processing the protein, or not reaching the surface, or reaching the surface but not functioning. And for that, we have two different types of modulator called potentiator or corrector. The first one was discovered in 2012, the ivacaftor, which is amazing modulator, but unfortunately, this ivacaftor only worked for the class 3, so 10% of the CF population. But then recently, 2 years ago, the Vertex company came out with the Trikafta, which is a triple combination of both potentiator and corrector. And this is covered almost 70% of CF mutation. Just briefly through the studies, the ivacaftor, which is the first modulator discovered, improved lung function by at least 10%. It reduced the sweat test, normalized the sweat test, improved the weight gain, and less exacerbation. And the same thing for the children. A later study was for children below age of 12. For the Trikafta, which can cover almost all the delta F508 mutation and other mutations from most of the CF population, in 2019 it showed that for children age of 12 and above, it also improved the lung function and reduced significantly the infective chest exacerbation. And the same thing, recently they published an open label. They didn't even use RCT for these children because it's not fatal. We know that it's rare. So they used only for all the children, they gave the Trikafta, listed between 6 and 12, and they looked at the lung function, improved weight, improved this exacerbation, sweat test normalized.
Fabulous, Dr. Rania.
Real world clinical outcome safety, there are lots of studies and case reports. There's a bit of talk of side effects on headache and a bit of neurocognitive side effect, but with a medication that can save lives, this is really minimal side effects. And there is now a study going on for starting Trikafta for toddlers, like between age of 2 and 5, and we're still waiting for the results. That's all brilliant, amazing news. But what are the challenges? The challenges here in UAE, we don't have, except one center in Abu Dhabi SKMC, proper CF center, we really don't have any proper CF center here. We got few trained doctors who work in the big CF centers in either in the UK or USA, but like proper CF centers in Dubai, we don't. Lack of support of insurance companies. I don't know how they can get away with it, insurance companies in these countries, but they don't insure children with genetic disorder. And obviously, patients' access to the new modulator, these are hugely expensive. Now it's becoming cheaper, so the last thing I heard that I can get my patients CFTR here in Dubai with a cost of 360,000 dirham a year for these tablets. This is cheaper. This is like half price. Okay, take home message. Cystic fibrosis is a genetic disorder that affects multiple organs. Newborn screening, really important. Most of the UAE centers now have newborn screening, lead to improvement in clinical outcome and survival. And diagnosis of CF, you need sweat tests and genetic study. And patients should be managed by an experienced CF center. And early recognition of complications and treatment improves survival and quality of life. And modulator like Trikafta are known to have a transformative effect on health and well-being among these patients. Thank you.
Thank you so much, Dr. Rania. Okay, one question. I'm going to hand you the microphone from here.
Thank you so much, Doctor, for the great presentation. I just have one question as a medical student. So the first case that you presented, the patient had an NTM infection in which you managed not to treat with antibiotics or antibodies. So what did you do for the infection?
What we did for infection?
Yeah, the NTM infection.
Right, okay. So when we say infection, means infection with symptoms. And to diagnose NTM infection in this child, in a CF child, we need to, one, isolate the bacteria, two, have clinically symptoms, three, changes in the CT scan in keeping with NTM infection. And because this child improved, he was treated for the other two bacteria, improved after 2 weeks of IV antibiotic, and the CT scan wasn't that convincing. We decided not to treat, and so we didn't consider it as infectious. NTM is a common bacteria that we have all around us, but it doesn't affect us healthy. With a healthy lung, it doesn't really affect us, but it affects cystic fibrosis patients.
Thank you.
But we will monitor, obviously, these children will keep monitoring them. So what if this child started to get further problems with the chest infection not responding to the usual antibiotic, we have to consider NTM again.
Thank you. We have 2 more questions, if we can go brief.
Thank you, Dr. Rania, for your informative lecture. I have two questions. One, the neonatal screening, if you have positive serum immunotrypsin gene, should be confirmed by genetic test?
If the first one is positive,
Yes.
the IRT, you repeat within definitely the 3 weeks of life.
Is negative?
If negative,
It's
if negative, and the child not symptomatic, don't do anything.
If it's positive, confirmed by genetic test?
If it's positive, the second one, you have to refer to a CF consultant. But in general, you have to do sweat test first.
And first month of life, some false positive, some false negative.
Yeah,
Not
but
this.
if the
Okay.
first one is positive and the second one is positive, this is CF until proven otherwise.
Okay.
Until proven otherwise. Because missing the diagnosis has a significant.
About your two cases, there is one for 14 years old and other 15 years old with bronchiectasis. Too much delay to refer to you, or that they are delayed to diagnose the cases? And the second question about the gut symptom signs. There is no both only recurrent chest infection. There is no diarrhea, loose motion like this. You know, the cystic fibrosis started from infancy with gastric symptomatic.
The first child is a good CF patient. Actually, he's one of the good spectrum because he managed from early on by Power CF Center in USA, even that he's class 1. The second child, I think she has all the complications. I'm sure she's got diabetes. I'm sure she's got osteopenia. I'm sure that she's ended up with pulmonary hypertension. I'm sure she has. She only came twice. I had lots of referral plans, and they disappeared. Got scared properly.
One last question.
Thank you, Doctora, for sharing your experience. It's just a comment. I would like to share our experience in Oman, as we are related, in the region. So we have a prevalence of estimation of 10.3 per 100,000 of cystic fibrosis. There was a recent paper published last year, reported almost 223 patients in Oman who received treatment over 15 years. And we have 23 variants, mutations in Oman. 65% of them had the same recurrent mutation, and 3 were novel. Also, to add to this, we had some patients with negative genetic testing, but their symptoms were mimicking the cystic fibrosis with a negative sweat test. So we did some research with Centogene, and we found a new gene also, which was published last year, called AGR2. And some patients also will end up to have ciliary dyskinesia. They were misdiagnosed as cystic fibrosis. Thank you.
Thank you. Can I check, do you have newborn screening? Is that the prevalence without news? I guess the cystic fibrosis in the region is pretty much underestimated, but now we have the newborn screening that evolving in UAE. We're going to see more and more of these patients. In terms of the new mutations that we found, yes, I worked in research in Gaza actually on cystic fibrosis populations, and they have at least 250 patients diagnosed there, and these are patients diagnosed based on severe symptoms. So imagine, like, these are the patients who were all over, and then they done sweat test and they have cystic fibrosis, and 20% of them have a new mutation, not being identified or reported anywhere else. So in our regions, that's why I'm saying, if you're suspecting cystic fibrosis, and you want to refer for genetic study, refer for whole exome sequencing, because the chance that we're going to have new mutations not identified in the Caucasians, like European and American population, is quite high.
Thank you so much, Dr. Rania. For any other question, please catch her in the break, and we'll need to proceed. But first, I would like to present the certificate of appreciation to Dr. Rania.